Now for our seniors, the Medicare prescription drug, the Medicare Part D prescription drug donut hole is going to start to be closed. In 2010, seniors who get into the donut hole will receive a $250 rebate check. Next year, there will be a 50% discount on brand name drugs and coverage of generic drugs once people actually get into the donut hole. And by 2020, the donut hole will be gone, so that seniors will have full coverage of their prescription drugs. In 2010, the insurance companies will not be able to practice rescission anymore, this dropping of people once they get sick. There will be the elimination of the lifetime benefits on, or lifetime caps on benefits. So that will go away in 2010, and the cap on annual benefits will go away in 2014. Now let me take a moment to talk about small businesses. You know, small businesses are an interesting thing because they affect a lot of physician practices as well. Certainly physicians that are in private practice are essentially, many of them, most of them, small businesses. So this sort of cuts both ways for a lot of physicians as well as obviously a lot of many small businesses. So as I mentioned before, if you have less than 50 employees, you're totally exempt from any fines. And what will happen in 2010 is that small businesses will receive a tax credit that is up to 35% of the employer's contribution to a health insurance plan for their employees. Even nonprofits can get a 25% credit because, again, this is one of the places where people just cannot afford to get or to offer insurance. And then by 2014, when the exchanges kick in, small businesses will be able to get up to a 50% credit for their employer contribution to their employees' health insurance. I'm sure most of the people in this room know that the vast majority of employed people who don't have health insurance actually work for small businesses. You know, most large companies do offer insurance, but small businesses frequently cannot afford it. So this will be a really important component in getting people covered. The other thing that's going to happen in 2010 is that private health insurance companies are now going to have to start reporting the percentage of premium dollars that they spend on health care. And then in 2011, if they're spending less than 80 or 85% of those dollars on health care, they're actually going to have to give rebates to their policyholders. So that'll be an interesting one. I can't wait to see how that one actually plays out. Many people have expressed concern, and understandably so, as to whether or not there will be enough doctors to take care of all the people that are now going to suddenly have health insurance. So the legislation has a number of components in it that I believe will really help to address that problem. We need more primary care doctors in this country. There's just no question about it. And in this legislation, there are provisions that will increase the number of residency training slots for primary care physicians, so there'll be more training positions available. They will promote trainings in outpatient settings rather than traditionally all doctors are trained in hospitals, even though eventually most doctors go out and practice not in the hospital. So there's going to be more of an emphasis on training people in outpatient settings rather than in the hospital. There's a tremendous amount of money to help doctors pay back loans. You know, the average medical student now has something close to $200,000 of debt when they graduate from medical school, you know, combination of college and medical school. And that, without question, deters a number of people from choosing primary care practices because those doctors do not make as much money as specialist physicians do. So there will be lots of money to help primary care doctors actually pay back their student loans, and greatly increased funding for the National Health Services Corps, which is a program that young doctors can do for a couple of years that will pay back all of their loans in full. Also, there's going to be some increased payments to primary care doctors who are taking care of Medicare patients. So a 10% bonus payment to primary care physicians and general surgeons who are practicing in medical shortage areas who see Medicare patients. And very importantly, there will be an increase in Medicaid payments. So our program for the lowest income among us, Medicaid tends to pay primary care doctors hardly anything. I mean, truly not enough to cover their costs. So in this legislation is money to increase payments to family medicine doctors, general internists, and pediatricians up to Medicare, 100% of Medicare rates, which will help those folks quite a bit. There is $11 billion to increase community health centers, which is going to result in the construction of a number of community health centers. there are very important provisions, especially to me as a physician, for something called Patient-Centered Outcomes Research Institute. And this will be an institute that helps conduct something that we call comparative effectiveness research. So what does that mean? Well, most of the data that doctors have about drugs and new devices was paid for, the studies were paid for by the people that made those new drugs and those new devices. And so you can imagine that sometimes we wonder if those studies are quite as comparative as we would like. And many times those studies don't compare the new drug to the much cheaper generic drug that we know is extremely safe. You know, those studies are almost never done because drug companies have such an investment in bringing these new drugs out. They don't want to really take the chance that maybe this new expensive drug doesn't perform quite as well as an older, cheaper drug. So this institute will now start to conduct those studies, and that will give doctors tremendously better information so that together with our patients we can make the best possible decisions for each patient. We'll be able to give our patients much more unbiased information when we're making some of these choices. There's a lot of increased funding for public health infrastructure and preventive care. And the other thing that goes into effect in 2010 is this indoor tanning services tax, which has really gotten a lot of controversy from people who run indoor tanning services. But there will be a 10% tax now to go get your tan, during the winter at whatever place. I don't know, that is a big controversy. Absolutely. So in 2011, there's some additional things that will start to kick in. One of them is that, and I actually didn't know this until the last year or so, but Medicare pays for one physical when you enter Medicare for free. And then after that, you're on your own. Isn't that crazy? We don't do preventive care very well in this country. And so this bill is all about turning that on its head and making sure that everybody gets all the preventive services that will keep us healthy in the first place so that we move away from what we like to call our sick care system and actually become a health care system. So Medicare, starting in 2011, everyone in Medicare will get an annual free physical, no co-pays or anything that go along with that. There will be a center started to actually look at new ways to do payment reform to physicians and hospitals and others in the effort to reduce cost and increase quality. There will be a program that starts in 2011 to help people who are leaving the hospital. You've probably heard in a lot of the press over the last year how many people bounce right back into the hospital once they've been discharged because they just don't have services at home to help them stay at home. So there's a whole transitions program that's going to start in 2011 with the goal of keeping discharged patients at home and keep them from bouncing back into the hospital. Now, one of the biggest important things that's going to happen, and hopefully this will happen in a very robust way, is starting to help physicians figure out how to deliver care in a more efficient, higher quality, less costly way. And one of the ways that that's going to start is by the creation of something called an accountable care organization. And what that means is that doctors will be linked together financially in ways that if patients do well, and they maintain their health, and they stay out of the hospital, and they are taking their medicines, and everything is good, that those doctors will benefit from that. And that's really how those doctors will get paid. Our current situation is that we only get paid every time we do a thing. So a thing can be a visit, an operation, whatever, but there's no incentive to keep people out of your office, which is really kind of the goal here, right? Every incentive that we have as doctors, not that we actively think about this, but when you step back, every incentive we have is to keep people in our office, not out. And so that clearly has to change. And so that's what accountable care organizations are all about, is starting to keep people out of our offices and to get paid for that, because really that's how it should be.